I'm going to speak about novel strategies for management of endoscopic complications. So in the last few years, there has been a huge expansion in the field of endoscopy, especially therapeutic endoscopy, as well as third space endoscopy. And with this expansion, there has been a need, a crucial need, to develop new novel ways to tackle complications that can rise from such procedures, mainly to tackle the complication or even prevent them, mainly bleeding or perforation. And the tricky part here is there is no one solution for all complications. We have to develop multiple strategies to deal with those complications. It depends on the availability of tools inside your endoscopy unit, the experience. Some techniques or some instrument needs more learning curve or steep learning curve compared to others. And even if you have the same complication in different organ, the management is different. Because, for example, in the stomach and the rectum, where the mucosa and the submucosa is thick, the management of perforation and closure of the defect is different than if you have this complication in the colon or in the duodenum. Not only the thickness of the wall, but also the ability to maneuver the scope within the lumen is different, where in the stomach and the rectum, it's easy to maneuver the scope, but in the colon or in the duodenum, it's a little bit restricted. So it's important to know multiple ways to deal with those type of complications. I'm going to speak about some of the new or relatively new novel ways to deal with those complications. I'll not be able to go through all of them in detail, so I'll speak briefly about some of them. The first one is the mantis clip. So from the name, it has mantis-like claws at the tip, where it helps in anchoring the edge of the mucosal defect. It depends on the hold and drag maneuver, where you catch one edge of the defect, then you drag it all the way to the other part of to the other side of the defect, open the clip slowly and try to catch the second part or the other part or the other side of the defect while maintaining the first part anchored. And we can see in the image on the right side a demonstration of that technique. It can help in closing the defect in the stomach, also in the rectum in the colon as well. In this study that evaluate the performance of mantis clip in closing the defect in ESD in colon, they enrolled around 52 patients. The success rate was pretty high, around 98%. And you don't need to add multiple clips, mantis clip to one defect. You can close or use one clip, then that will approximate the middle part of the defect. Then you can use the regular clips to close the rest of the defect. The second type of clips, the new clips, is the dual action tissue closure device. This is a 3-armed through the scope defect, as you can see in the image on the left side. It has a blue arm and a gold arm with a blue and gold handler that work independently. So the idea behind it is that you close one side or you catch one side of the defect with, for example, the blue part, then you drag it all the way to the other side and catch the other side with the yellow or the gold side. Then you fire both arms simultaneously at the same time. In one study that evaluates the performance of that clip, including a patient who underwent EMR or ESD and for large non-polypoid colon lesions, the complete closure success rate is around 96%. And again, you don't need to use multiple clips multiple DAT clips to close the whole lesion. You can use just one or two clips to approximate the two edges and just go with the regular clips to close the rest of the lesion. There's a third technique which is called clip-assisted suturing techniques, where you use clips, but all regular clips, but also you may need to use another instrument such as endoloop or suturing threads. One of them is clip-on-clip method, clip-on-clip closure method, where you place the first clip at one edge of the defect, then you use a second clip to catch the handle of the first clip, then use a third clip to to go through the two arms of the second clip and close it to the other side of the mucosal defect. The other way, another way of doing clip-assisted suturing is the A-lock, where you approximate two clips using the suturing thread. Then you fire a ring over them to make them permanently close together. And in one study where it included 48 patients, the complete closure rate was more than 95%, with no much complications. The clip fixed endo loop, it's utilized using the regular clips to fix the edge of the endo loop to the edge of the mucosal defect. Then after the edges are fixed, you just pull the endo loop, trying to approximate the edges of the mucosal defect together. The loop 9 closure technique, where the endoscopist has to assemble the loop 9 outside, then insert it into the lumen, and by using two clips to fix the loop to either side of the mucosal defect. And the last step will be just to close, pull the tail of the loop and close the defect. And in this study, where they evaluated around, I think, 100 patients, more than 100 patients, the success rate was pretty high, was 96%, and no much complication arise from those lesions. The last one is the internal traction assisted suspending closure technique, where you apply a clip that is attached to a rubber band to one edge of the clip. Then the other part of the band, you fix it to the contralateral side of the lumen. That will give you some traction to the edge, and you can just complete the whole closure with regular clips. The benefits of those clip-assisted closing devices is that most of them you don't need to reinsert the scope again. So if there is a defect, you don't need to pull the scope all the way like you do in over the scope clip or suturing and some suturing device. But they are not perfect. Most of them, they are not perfect in closing full thickness resection. You still need to use the over the scope clip or even the some suturing device. Over the scope clip has gained some popularity in the last few years. They start to become a primary or even the salvage therapy for many complications, decreasing the need for surgical interventions. The benefit of over the scope clip in compared to through the scope clip is that they have larger size. They can capture larger area, and they apply more compression pressure. They can be used for hemostasis. They can be used for fistula closure. They can be used for perforation closure. The kit, it contained an application cap, the mounting clip, the handling wheel, the thread, and thread retriever. Also, there is some auxiliary catheters, such as the hook catheter or even the grasper. As you know, it has three types. The A type, which is it has blunt, without teeth edges. It helps in decreasing, like managing the bleeding. Type T, which has spikes at the end of it, which helps in closing the defect, or even used in area with very thin mucosa, such as the colon and the duodenum. And the GC type, which has longer teeth, which is used in the gastric mucosa, or in the stomach, because the gastric mucosa is pretty thick. In this systematic review, where they evaluate the performance of over the scope clip, they included different, like the usage of over the scope clip in different categories. But one of them is closure of endoscopic resection, where you can see that the success rate was around 92% in this subgroup, with very low overall adverse effect. They evaluated the usage of over the scope clip in closing the defect post-duodenal EMR or ESD. In this study, where they included in 18 patients where they removed submucosal lesions in the duodenum, the delay perforation and the delay bleeding was almost zero. In this case report, where they applied over-the-scope clip to decrease the risk of bleeding on patient who has a thrombocytopenia due to malignancy, and they have just to close the defect with over-the-scope clip. The ESGE guidelines, they recommend using over-the-scope clip through the scope clip if the defect size is more than 10 millimeter, and the success rate to treat such perforation is more than 85%. You can see in those two cases where there is a duodenal perforation due to ERCP, type 1 duodenal perforation, where the over-the-scope clip has been used to close the defect. It has been also used in the, like in the first row, you can see that it's been used for post-EUS perforation in the esophagus, where it was successful to close the defect in the distal esophagus. There was one study where they evaluated the usage of over-the-scope clip in treating duodenal perforation post-ERCP, type 1 duodenal perforation, which is a perforation of the lateral wall of the second part duodenum, where 8 patients out of 20, they underwent over-the-scope clip, while 12 patients, they underwent surgery. Both of them, they have good success, but the time to oral intake, as well as the median hospital stay, was better and shorter in patients who underwent over-the-scope clip. You can also, when you use it to close a defect, you can assess the success or the success immediately by just putting contrast into the lumen and see if there is any extravasation or not. Not only it has been used to close the defect or decrease bleeding, it has been used to fix the stent, to prevent migration of the stent. The success rate for that, the technical success rate was pretty high. The reported stent migration was comparable to endoscopic suturing. Another way to deal with endoscopic complication is suturing device, whether it's over-the-scope suturing device or through-the-scope suturing device. Initially, it has been used for bariatric endotherapy, but lately we start to use them to close defect, decrease complication, decrease risk of bleeding, post-EMR or EST. It can be used in the upper GI tract or in the rectum as well. Also, it has been reported to have high success rate in treating post-endoscopic complications such as like esophageal perforation due to dilatation, like in such case. The issue with the suturing device is like you have to have a special equipment, obviously, and it has a steep learning curve. So that's the downgrade of it. The thing that I want to speak about right now is endoscopic vacuum therapy. So vacuum therapy has been used by the surgeon in laparotomy surgery. We know that it gives continuous drainage and prevent accumulation of the secretion. It reduces local edema. It increases the local perfusion and promotes granulation tissue formation. Endoscopically, it can be pre-made packages like you see in the right side, or we can assemble the sponge ourselves using the NG tube suturing thread as well as the sponge itself. Also, it has been incorporated with the esophageal stent, so we can insert those type of stents that is coated outside with the sponge in patients with post-surgical leak. We can insert them in two different ways. We can insert it intra-cavity, where you have to put the sponge itself inside the cavity or the collection, or you just can put it intraluminal, where you just put it inside the esophagus without trying to push it within the cavity. It has been used to treat post-surgical perforation or leakage, but also it has been used to treat post-iatrogenic perforation. Like in this case, in this study where they included 10 patients who underwent EVT for esophageal perforation due to multiple reasons. 4 of them, they have esophageal perforation due to pneumatic dilatation, and one of the patients had perforation after diverticulotomy. You can see that the complete closure of the perforation was around 100%. And even it has been used for perforation in the upper esophagus without compromising the airway. And with each time you change the sponge, you can see endoscopically that there is more formation of the granulation tissue and reduction of the size of the collection. Like you can see here first in slide A, or in A, that the perforation is pretty huge. But in D, like in the next 1 week, you can see significant reduction in the size of the collection. In this retrospective study that included 27 patients who had esophageal perforation, where more than 50% of them was iatrogenic, the success rate was around 90%, which is pretty significant. We can use it not only in the esophagus, but also for iatrogenic perforation in the rectum. So in this case, where you can see that there is a huge defect in the rectum due to retroflexion, by applying endoscopic vacuum therapy, there is significant reduction in the size of the perforation with subsequent changes of the vacuum therapy. The last thing I'm going to speak about it is the hemostatic powders and gels. So we're all aware of the hemospray, the endoclot, and blood stopper. They are life-saving. We can use it in case that we are not able to recognize or control the site of the bleeding. But also we started to have more new generation of the hemostatic powders. There's a CEGP 003 and the UIEWD coming from South Korea, which are showing to be very effective. They are helpful in anatomically challenging area with poor visualization, with diffuse bleeding and friable tissues. There is no much side effect. There are very few side effects. The most prominent one is visceral perforation, which is just case reports, and self-limited abdominal pain. There have been many case reports where they described usage of those powders for post-EST and EMR bleeding with good success, but there is no big trials. So in summary, there is crucial need to adapt different strategies to prevent and treat complication post-endoscopy. There is evolving techniques and evolving tools coming in the pipeline to treat such complications. And knowing and mastering those new techniques is not a luxury anymore, it's a must. Thank you.